Hi, everyone. My name is Sarah Sims, and we are pleased that you could all join us for this lecture in our Volume 5 of our 12-week Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsors for their financial support for the series. And before we start, we want to make everyone aware of our YouTube channel. Every No Neuropsychology and No Neuroanatomy lecture is available for your viewing pleasure. Be sure to go check it out, subscribe, and like our lectures. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and the YouTube channel later this week. Now, it's my pleasure to introduce Dr. Staffaroni for today's lecture on the neuropsychology of FTD syndromes. Dr. Staffaroni is a clinical neuropsychologist and assistant professor with a focus on frontotemporal dementia. His current projects include modeling disease progression in FTD using clinical and biomarker data, as well as developing and validating endpoints for clinical trials. As a co-investigator on the North American FTD Consortium, he leads 2 studies of remote digital data collection in FTD using smartphone assessments and sensor technologies. Thank you so much for joining us today, Dr. Staffaroni. Go ahead and take it away.
Thanks, Sarah, and thanks for the opportunity to speak today. As Sarah mentioned, I'm an assistant professor at UCSF in the Memory and Aging Center, and I've been here since 2014, where I was training as a practicum student, and then returned for a 2-year postdoc before joining time. So I'll talk today about the neuropsychology of FTD syndromes. Start off, I don't have any relevant disclosures. I mainly put this slide up to make it clear I don't have any financial involvement with Data Cubed Health, which is a third-party vendor that we've been working with to develop a smartphone application for FTD, which I'll talk about later. So to start, I'm going to give a brief background on the FTD syndromes and underlying pathology. I'll discuss the role of neuropsychological testing in the diagnosis of FTD, both in discriminating FTD from AD and differentiating among the PPA subtypes, and a little bit about differentiating primary psychiatric disease from behavioral variant FTD. I'll talk about some exciting new developments regarding the role of neuropsychological testing for early detection and monitoring in the familial forms of FTLD, and wrap up by discussing our newest endeavors into remote digital phenotyping. So there's 2 terms, and they sometimes get used interchangeably, but they shouldn't. So FTLD and FTD. So FTD, or frontotemporal dementia, it refers to the clinical syndrome, whereas FTLD, or frontotemporal lobar degeneration, refers to the underlying pathology, so similar to Alzheimer's disease pathology. FTD is as common as Alzheimer's disease as a form of early onset dementia, and there are several main clinical syndromes. So there's the behavioral variant. There's 2 forms of primary progressive aphasia, the semantic and non-fluent variants. And most of what I'll talk today about, highlighted here in orange, are these 3 canonical FTD syndromes, as neuropsychology is really, maybe you could consider, most central to the role of diagnosis in these syndromes. But also under this umbrella of FTD is progressive supranuclear palsy, or PSP, and cortical basal syndrome. And then a subset of patients with FTD also develop motor neuron disease. As I mentioned, FTLD refers to the underlying pathology, and here on the right in this figure that's courtesy of Bill Seeley, we see the FTD relationship between syndromes, the heterogeneity of the clinical syndrome, unique challenge to designing clinical trials are familial and inherited in an autosomal. So to start off, these are the diagnostic criteria for a behavioral variant of FTD. So for possible, they need to meet 3 of 6 of these symptoms, and they need to be early and prominent. So behavioral disinhibition, apathy or lack of inertia, loss of sympathy or empathy, perseverative, stereotyped, or compulsive ritualistic behaviors, hyperorality and dietary changes, and executive function deficits with relative sparing of memory and visual spatial functioning. So neuropsychology is written into the diagnostic criteria, although as we will see in a moment, it's not always or often that clear. And then to go from possible to probable, you also need some imaging supporting frontal or anterior temporal lobe involvement. So misdiagnosis of behavioral variant FTD is common. Common misdiagnoses include psychiatric disease or Alzheimer's disease. Early and accurate diagnosis is important for prognosis, treatment, and helping families understand the changing comportment of their loved ones. Blood and imaging Alzheimer's disease biomarkers, though, are becoming widely available with high diagnostic accuracy. So a lot of work was focused on using, a lot of research was focused on using neuropsych testing to differentiate FTD from Alzheimer's disease. I'm going to still discuss this briefly because it's still a common diagnostic question, and I think it's a good vehicle for discussing cognition in FTD, but biomarkers of AD are quickly becoming central to this differential. However, we still don't have molecular biomarkers of FTLD pathologies or highly accurate methods for syndromic diagnosis using biomarkers. So diagnosis still relies heavily on clinical assessment. And so how does neuropsychology fit into this diagnostic picture? So as I mentioned, executive dysfunction with sparing of memory and visual spatial functioning is written into the criteria, but subsequent work has brought this into question. So the frontal lobes were classically taught as the anatomical substrate of executive functioning. FTD is a frontal disorder and AD is a temporal parietal disorder. So FTD should be more impaired in executive functioning, right? Well, on the left here, we see that Alzheimer's disease dementia here and behavioral variant FTD participants perform similarly on a composite score of executive functioning tasks. So both perform worse than sort of amnestic MCI and controls, but they're at a similar level. And then on the right, this is a comparison of how AD dementia and BVFTD participants perform on tests from the NIH Examiner, which is a computerized battery of executive functioning tasks. So BVFTD in red do show impairments compared to controls in the majority of cases, but so do Alzheimer's disease patients. And after controlling for cognitive severity, although a couple of executive tests, antipsychotics and letter fluency, seem to be more impaired in FTD than Alzheimer's, the majority of tasks are equally impaired. So for example, set shifting, inhibition, working memory all seem to be at a similar level, as does category fluency. This is another paper showing similar findings. So at baseline here, Alzheimer's disease patients in this column and BVFTD patients in this column perform really similarly on working memory task and a classic trail making test. FTD patients do have more errors on the task of response generation and inhibition and slightly worse letter fluency, although there's highly overlapping scores. And looking longitudinally, AD and FTD patients decline at a similar rate on all tests except the errors. So we've just seen that executive deficits are not specific to FTD, but are they sensitive? So we'll go through a sample case. This is a 58-year-old right-handed Caucasian man who worked as a computer programmer. He was referred for progressive changes in behavior and cognition over the last few years. And these were his early symptoms, so new compulsive habits and obsession with television, started buying urges for things like videos, swords, and shields, became apathetic. He was eating more sweets and gained 30 pounds over 2 years. He was socially inappropriate and had less attention to dress and hygiene. So, falls squarely within, a diagnosis of behavioral variant FTD. MRI showed a pattern of atrophy that involved medial frontal, orbital frontal, and right temporal lobes, so classic for BVFTD. And this case progressed significantly over the course of a couple of years. Where he was nearly mute and couldn't complete any cognitive testing a couple of years later. So let's look at the executive functioning and his cognitive performance at this baseline visit. So he was at ceiling on the MMSE, and then his performance is actually within the average range on several classic tests of executive functioning shown here in orange. He was a little bit low on semantic fluency. His confrontation naming was fine. He was able to recall 8 of 9 words on an immediate recall trial for the CVLT short form. Some forgetting over delay, but he improves a bit with recognition. So I think this is really critical. We see a lot of patients referred who have had neuropsychological testing, and one of the conclusions of the report states that this patient had spared executive functioning. So this is likely not FTD. I think here's a really nice case that's sort of representative of what we see, in that it's really not always impaired. And regarding the lack of specificity, the overlap in performance between Alzheimer's disease and FTD no longer seems surprising. So the evolution of cognitive neuroscience and functional imaging has elucidated an integrated frontal parietal system that supports executive functioning. This system, however, is distinct from the ventral salience network shown in red and the semantic networks that support behavior and social cognition that are often affected sort of early in FTD. And so imaging also helps explain the lack of sensitivity of these tests. So early BV-FTD affects these behavioral networks early. Here at the top, you could see patients with very mild disease. So the salience networks are often affected early rather than this executive frontal parietal network, and therefore the executive deficits may not manifest until the disease has progressed further. There are some tests that do seem to be more sensitive to the particular anatomy of behavioral variant FTD. So here's an example of one of them. This is the DCAPS design fluency tasks, where participants are shown a grid with dots. They're asked to connect these dots to make different figures in each square using only 4 lines. This is the shifting condition where they have to draw, they have to alternate between empty and full dots. So here's an example of design fluency performance in a 46-year-old BV-FTD patient who's otherwise fairly cognitively intact. You can see that his MMSE score is a 26. And you can see that these repetition errors occur on back-to-back designs, suggesting perseveration and poor error monitoring. So here's another area where he's making the same errors again and again. And Kate Possin at UCSF investigated this phenomenon and found that although patients' total performance could be caused by damage in many parts of the brain, which reflects the multiple facets of cognition required to complete this test, that repetition errors were actually fairly specific to the lateral orbital frontal cortex, and making more than 4 errors on this task was fairly specific to BV-FTD in this mixed diagnostic sample. And earlier, I showed a paper that highlighted errors, being more common in BV-FTD than the Alzheimer's cases. This is another more recent paper showing total performance on the trail making test here is similar between FTD patients in red and Alzheimer's disease patients in blue, but the FTD patients tend to make a greater number of errors across the spectrum of disease severity. So from mild to, or from mild cognitive or behavioral impairment to mild dementia and moderate dementia. So how about the spared visual spatial performance that's part of the diagnostic criteria? So here's an example of a stimulus-bound patient.
Okay, now another one for you that I want you to do. Okay, put the blocks together to make them look like this design here.
So he's really only using the red sides of the blocks. Not a spatial deficit, but clearly he's going to fail this test and have really bad performance.
Okay, thanks. Can you get that one? Okay.
And here's another visual spatial test. This is the Benson figure copy. It's a little bit simplified version, similar to the Ray figure copy that we often use in research and in clinic. So here's an Alzheimer's disease patient who scored a 10 out of 17. And you can see that really the sort of what's driving this score are spatial distortions. Figures are, elements of the figure are placed in the wrong position. I want to contrast this to an FTD patient with the same score, but here it's more due to planning errors and perseverative errors. So for example, you see the circles that he draws or she draws across the figure in multiple places. So different cognitive mechanisms can drive poor performance, with bottom-up spatial perception deficits in Alzheimer's disease, and planning, working memory, and stimulus boundedness in BV-FTD. And the neuroanatomical substrates also differ in a pattern we would expect. It's a paper again from Kate Possin showing right parietal correlates of performance in Alzheimer's disease, but dorsolateral prefrontal cortex correlates in behavioral variant FTD. So what if there are memory deficits in a patient you suspect to have BV-FTD? Does this rule it out? This again is something that we see often in the conclusions of neuropsychological reports that come to us clinically. So many studies have shown impairment in memory scores in BV-FTD. So here, the results of several studies were summarized in a meta-analysis that showed memory deficits in BV-FTD with large effect sizes compared to controls, although not as large as Alzheimer's disease, but there are a large overlap in the test scores. Longitudinal rates of decline are similar between the two groups and memory scores. This is the same paper that I showed earlier. And so impaired memory should not rule out a diagnosis of FTD. This is just showing that same paper again, where cross-sectionally, Alzheimer's disease patients were in the direction of performing worse on all tests, but only 1 out of 4 reached statistical significance. And the longitudinal trajectory of these memory tests did not differ for any measures between Alzheimer's disease and FTD. So maybe these memory deficits are simply secondary to the executive functioning that I was describing earlier. So on the right, we see a comparison of pathologically confirmed BV-FTD in the darker shade of gray here, and PET confirmed Alzheimer's disease. And these are trials of a list learning task, trial 1, 2, 3, and 4 of the learning trials. See that both Alzheimer's disease and FTD drop off. There's certainly more rapid forgetting in the Alzheimer's disease cases, but BV-FTD really didn't conform to a more dysexecutive pattern, so they had similar rates of intrusion errors and comparably low rates of improvement with cued recall and recognition. We know that FTD can affect the hippocampus, and indeed this study and several others have described hippocampal correlates of memory deficits in BV-FTD. And there are also, as we learn more about the genetic forms of FTD, there are some of the familial mutations that cause amnestic Alzheimer's-like syndromes as well. So social cognition and behavioral components of behavioral variant FTD are thought to arise due to pathology in the salience network and the semantic appraisal networks. So measuring social cognition and behavior is a critical part of the clinical examination. So in addition to clinical observations, informant report is highly valuable. One example of a way to quantify that is the revised self-monitoring scale, which looks at socio-emotional sensitivity of the patient. So in the upper right, you could see that both sporadic cases in black and familial cases of FTD in red, that they show increasing impairments as disease increases in severity. And the bottom right here, you could see that performance correlates with key hubs of the salience network. And these imaging findings were recently recapitulated in a paper from the GENFI study, which is a European consortium studying FTD. And there are several tasks of the semantic appraisal network that are easy to evaluate through traditional face-to-face testing. So the social interaction vocabulary test, or the CIVET, is shown up here, where a single word is shown and you pick the picture that goes along with it. And then the dynamic affect recognition task is a task in which participants are shown videos and asked to identify the emotions. And then there's also sort of more traditional static affect naming tests that kind of get at this system that is often affected in both FTD as well as sort of semantic variant of PPA, as I'll talk about in a moment. There are other tests out there that look at correct interpretation of social scenarios. So just a brief note on distinguishing BV-FTD from a primary psychiatric disorder. So informant report, clinical history, and behavioral observations are likely more informative than neuropsychological testing. So neuropsychological testing has been found to poorly differentiate BV-FTD from primary psychiatric disease. And one study actually showed that primary psychiatric patients performed worse than BV-FTD. Another study showed that naming, but not executive functioning or memory tests were moderately discriminative of primary psychiatric from BV-FTD. I think many of us are very optimistic that molecular biomarkers will help further improve differential diagnosis here. And an international group of experts recently published this really excellent review on the topic that I'd refer you to if you have further questions. So just to pause for a moment to summarize, so executive deficits are not overly sensitive nor specific. They don't differentiate FTD from PPA either. Errors, particularly perseveration, offer some specificity. Memory deficits should not rule out FTD, and a process approach to visual spatial performance is important for distinguishing which cognitive processes are really contributing to poor performance on that test. Measurements of social cognition and behavioral observations help support a BVFTD diagnosis, and an in-depth interview with an informant is really critical. So I want to underscore that. So I want to shift gears and talk about neuropsychological testing in the differential diagnosis of primary progressive aphasia. So each of the three canonical PPA subtypes has a different anatomy and different pattern of findings. So the first step for a neuropsychologist is really to assess each of these subdomains of speech and language. So spontaneous speech, repetition, naming, motor speech, syntax. And this is just sharing what the primary deficit in each of these different syndromes is. And then after assessing each of these subdomains of speech and language to help define the syndrome and pinpoint the anatomy, then test other cognitive domains to support or refine these conclusions. So we recently analyzed how a selection of language tests performed in a large cohort of over 1,600 patients collected through the National Alzheimer's Coordinating Center in the US. So this included over 600 BVFTD patients, 185 semantic variants, 168 non-fluents, and a little over 100 logopenics. And we compared them to 581 controls. And one goal was to understand the utility of the FTLD module and UDS tasks. So the FTLD module and the UDS are freely available versions of copyrighted stimuli that are, that could be prohibitive for some clinicians and research groups. And these measures are integrated into the National Alzheimer's Coordinating Center's research efforts across the country. So we looked at the cross-sectional diagnostic utility of each test, as well as looked at longitudinal changes, which I won't discuss today. I think it's important to make clear that we set a really high bar here of looking at a single test discriminating between these different groups. And, that doesn't map on a clinical practice in which you would consider multiple tasks together, along with clinical history and biomarkers, but I still think it's useful for highlighting the tests that we think are important. And one of the results of this project was confirming prior work showing that PPA participants performed worse than BVFTD on almost every of the FTLD module language tests. So before I get into this, I want to talk about each of the PPA subtypes. So the core feature of the semantic variant is, or semantic dementia, is the multimodal loss of semantic knowledge. So these patients perform poorly on confrontation naming tasks, particularly for low familiarity or low frequency items. They have impaired single word comprehension, and then at least three of the following. So impaired object knowledge. So what does a hammer do? They may not get. They have surface dyslexia or dysgraphia. So this is the ability to read or write irregularly spelled words in the English language that rely on semantic knowledge because they don't adhere to standard how the phonemes are typically pronounced. But they have spared repetition and spared motor speech. And the atrophy in these cases, or the disease, is really centered around the anterior temporal lobe, particularly on the language dominant side. And in our analysis of the UDS and FTLD module tests, we found that naming impairments were the best at differentiating the semantic variant here in orange from the other variants. Particularly the multilingual naming test, or the MINT. Problem is there is a lot of overlap, particularly with the logopenic variants who struggle with naming. I think key to this differentiation is understanding whether there is a semantic deficit or whether it's just a retrieval deficit, which is what we see in the logopenics. I think multiple choice options on naming tests, like the Boston naming test, really help with that. Those multiple choice options are not formally available for the MINT yet. Several other tasks shown here can help bolster the conclusion that there's a semantic deficit. So single word comprehension can be tested with word picture matching or the PPVT like I just showed. Semantic association tests also have a large literature behind them. This is the version from the FTLD module where they have to choose which pair is shows two semantically related pictures. I mentioned surface dyslexia before, so where patients have trouble reading the irregularly spelled words. So they would say pint or yacht or gnome, or often spell gnome as N-O-M-E. And then a famous faces task, which shows a number of faces of famous people and asks participants to basically name that person, is also helpful, particularly with right temporal lobe deficits. So also impaired is semantic fluency greater than phonemic fluency. Verbal memory is often impaired in these patients. Motor speech, repetition, and visual spatial functioning is impaired. Maybe in some cases, visual spatial functioning may actually even be improved. And there's a relative perseveration of executive functions. So shifting gears now to the non-fluent variant. So this variant of PPA is characterized by agrammatism in language production, often with short, simple phrases and omissions of grammatical morphemes, so function words like it, and, or the. Their speech can also be effortful with halting speech and inconsistent distortions, deletions, substitutions, insertions, or apraxia of speech, which is often seen as transpositions of speech sounds. They're often impaired in the comprehension of syntactically complex sentences, but single word comprehension and object knowledge are spared. And then the diagnosis is supported by atrophy or hypometabolism in the left frontoinsular structures. So we found that the ratio of phonemic to semantic fluency was the best measure for discriminating the non-fluent variants from the other variants. So they show poor phonemic relative to semantic fluency. And this makes sense given the left frontal anatomy of the syndrome. So phonemic fluency we often think of as being driven more by left frontal anatomy, whereas semantic fluency is often more temporal lobe anatomy. So non-fluents will have difficulty with grammatically complex syntax, word repetition, and really the majority of speech and language tests require expressive language. So one of the keys is really looking for errors and assessing fluency, motor speech, and apraxia of speech. Executive functioning deficits are common given the left lateral frontal anatomy. And typically these patients have relative preservation of memory, visual spatial functioning, and single word comprehension. All right. And lastly, the logopenic variant of PPA. So the cognitive impairment in the logopenic variant at its core is a deficit in the phonological loop or phonological short-term memory. So this manifests as impaired single word retrieval and spontaneous speech. So their fluency is interrupted by word finding pauses. They also have difficulty with confrontational naming, as I mentioned, but their semantic knowledge for those words or objects is intact. They're impaired at repeating sentences and phrases, and longer and more complex phrases are more likely to be impaired. And then at least 3 of the following. So they may make phonologic paraphases in spontaneous speech and naming. They usually have spared single word comprehension and object knowledge, so no semantic loss, spared motor speech, and they're not agrammatic. And the anatomy is typically the left inferior parietal, temporal parietal junction. And logopenic variant, I didn't mention it in my initial slide because it's typically caused in about 80% of cases in our brain bank by Alzheimer's disease pathology. And so the tests in the battery we looked at only moderately discriminated the logopenic variants. So forward number span and sentence repetition were the best. And we know these are very helpful clinical tests. So, when I see a patient with a suspecting logopenic variant and their digit span is very low, that's, really helpful for me as a clinician. But, I think part of it is that the repetition measures included here, they don't have the best psychometrics. They're only, I think, 5 items, and, they have a lot of ceiling effects. So the diagnosis of the logopenic is supported by phonological alexia, so they would have difficulty sounding out non-words because of the difficulty with their phonologic system. They do poor on naming, they make these phonemic paraphasias. Because of the anatomy, the temporal parietal junction, and with involvement of the angular and supramarginal gyrus, and Alzheimer's disease pathology, they also have impairment on calculations, oftentimes visual spatial tasks and verbal memory as well. But they're preserved in their single word comprehension and object knowledge, motor speech, and grammatical structure. AD biomarkers can help support diagnosis of logopenic variant PPA, And a recent paper also showed that progranulin mutation carriers, one of the causes of familial forms of FTD, that it also often presents with a logopenic variant aphasia. So with that, I'm going to switch gears and talk a bit about familial forms of FTLD. So I mentioned up to 30% of cases are familial. They're highly penetrant and autosomal dominant. The majority of these cases are caused by mutations in one of three genes. So the tau or the MAPT gene, the progranulin gene, and repeat expansions in the C9orf72 gene. And so these cases also have early age of onset. So progranulin, typically the age of onset is about 61, even earlier in the tau mutation carriers, and about 58 in C9. The majority of cases present with a behavioral variant FTD clinical phenotype, but PPAs are also common, and there's there you can see there's also some movement disorders in here as well, and some, up to 8% of progranulin cases also present with an Alzheimer's disease phenotype. And a lot of prior work grouped sporadic and familial cases, and so the neuropsychology of familial FTLD is being fleshed out. It's complicated as even within genetic groups. So within progranulin, for example, specific mutations can have specific neuroanatomical predilections and therefore distinct neuropsychological patterns. So in this brief talk, I'm going to focus instead on some of the exciting advances in identifying cognitive changes that are observed in prodromal stages of familial FTD before symptoms begin, and the use of neuropsychology for early detection and monitoring. And there are a surge of therapeutics that are being developed for FTD right now, and many of them are focusing on the familial forms. And pre-symptomatic familial FTLD offers the opportunity for prevention trials. And so to this end, we're interested in identifying participants that are close to symptom onset and enroll them into trials. And studies have shown that pre-symptomatic mutation carriers show declines in cognition prior to symptom onset. And novel tasks such as the camel and cactus task, which is a harder version of the PPVT, has been shown to detect these early cognitive impairments. So I'm a co-investigator on ALL-FTD. It's a 23-site North American consortium that studies both sporadic and familial forms of FTLD. And I'm going to show you some data that comes from this study. We also combined data from ALL-FTD with GenFI, which is the European consortium studying this disorder. This work is part of the FTD Prevention Initiative, or FPI, which was formed to bring together genetic FTD cohorts from around the world with the goal of planning and running clinical trials in FTD. So we took natural history data in over 800 mutation carriers and 400 non-carrier controls. We pulled in various different markers. So we have clinical markers. The CDR plus NAC FTLD is similar to the standard CDR that's used for Alzheimer's disease. It's kind of based on an informant interview. It's a measure of disease severity. It has some additional domains that are relevant to FTD. We actually had a lot of neuropsychological measures that were ready to be harmonized across the ALL-FTD and GenFI consortia. We have plasma levels of neurofilament light chain, a marker of neurodegeneration, and we had volumetric MRI that we used. We crudely kind of took large ROIs as a first pass of this. We took people across the disease spectrum, so from asymptomatic all the way up to dementia, and we allowed all the data that they had, so longitudinal data were included when possible. And I'm showing this because, so here we have the 3 different mutations that I mentioned earlier. For each genetic group, we selected a representative imaging measure in green, and clinical measure, or neuropsychological measure in orange, and overlaid those curves on top of the curves for that CDR score that I mentioned earlier, as well as plasma NFL shown here in purple. So the y-axis here shows how many standardized units these mutation carriers are from controls. The x-axis is the model's estimate of disease onset. So this is a Bayesian linear mixed effects model in which we jointly model all of these different measures that I showed you to estimate how far somebody is from their disease, which is shown as 0, and this corresponds to very mild symptoms. And so, a -10 is 10 years prior to onset, -20 is 20 years prior to onset. And what emerges are some interesting group differences in the dynamics of biomarker changes between these groups. So for example, in C9, we see very early brain atrophy diverging from controls as many as 40 years prior to onset, followed by NFL about around the same time. In progranulin, we see kind of changes that in imaging and NFL much closer to onset, and there's very dramatic clinical changes. And then in MAPT, we see NFL doesn't really change until much closer to symptom onset, but there is earlier medial temporal atrophy. And there's all sorts of things we can do with these data, like estimating sample sizes and selecting the best endpoint for each stage. We could look at enrollment criteria for clinical trial inclusions. But one of the things that stood out to me is, these standard neuropsychological measures really don't change in aggregate until about the time that clinical symptoms are noticeable by an informant. So it makes it challenging to think about, clinical endpoints that can be helpful in the earliest stages of the disease. So there's a lot of interest in digital cognitive testing in the hopes that it might improve our sensitivity to the earliest deficits. And we've been utilizing the NIH Examiner and all FTD for tracking changes over time. I mentioned this earlier as a battery of executive functioning tests that was developed by Joel Kramer and colleagues as an endpoint for observational research in clinical trials. So I'll show you data from the computer version, but we're now implementing this on iPads using the UCSF TabCat platform. So we took asymptomatic or mildly symptomatic mutation carriers and compared them to their non-carrier family members. So the examiner was sensitive to differences at baseline. So as you can see in the figure on the right here, mutation carriers in red performed slightly worse at baseline, but they showed more rapid longitudinal decline over time. And these results held when looking at those only with a baseline score of CDR of 0, so totally asymptomatic. And these declines were correlated with functional abilities and volume loss. And so I want to conclude by briefly discussing kind of what we've done since then in looking into remote digital assessments. So there's a lot of rationale for trying to use repeated remote digital assessments. So it may improve longitudinal phenotyping. We can increase the frequency of assessment, which might increase reliability and therefore sensitivity to the earliest changes. Testing in a natural environment enhances ecological validity, although it comes with a trade-off that the data may be more noisy. We can collect novel data streams like passive data. It could allow us to reduce patient and staff burden and allows us to centralize the collection and storage of data. And importantly, allowed us to do a lot of continued data collection during shelter in place secondary to the COVID-19 pandemic. So we've been developing the All FTD Mobile App for these reasons. This has been developed with the support of the Tau Consortium, the Bluefield Project to Cure FTD, and the NIH. And we've been working with DataCubed Health, which is a company that was started by Paul Glimcher, who's an NYU professor and founder of the field of neuroeconomics. So this smartphone application can be downloaded both for Apple and Android phones. There's a lot of reasons that we chose this. There's fully customizable questionnaires that you can easily build in. There was an existing suite of cognitive tests, mostly executive functioning and processing speed, similar to the NIH Examiner that I just showed you had, that we saw there was potential there. But we've since then built up our abilities to also collect motor data and speech and language. We collect passive data through the app, so step count, battery life, in a subset, we're getting GPS data. There's a study partner version of the app that allows us to do more frequent informant monitoring. And we also built the ability to pay participants directly through the app. So when they complete their tasks, they receive an Amazon gift card code directly through this app. And so as I mentioned, a lot of the initial tasks were focused on processing speed and executive functioning. We've built up tests of gait, balance, and finger tapping. So this is an example of our finger tapping test. There's a single finger and an alternate tapping paradigm. We also developed the ability to collect speech samples while participants complete a variety of tasks like describing pictures and reading passages. So this was developed in collaboration with an international team of language experts, including Mary Lou Gorno-Tempini at UCSF, Mary Grossman at Penn, and Adam Vogel at the University of Melbourne. And we the speech samples are stored in a file format that allows for collaboration, so other researchers can analyze the acoustic and linguistic components of these recordings. So I'm going to end with a little bit of preliminary data. So we ran 2 different stages. There was a pilot testing phase where we did cognitive pre-testing and post-testing interviews in 10 healthy older adults and 10 study partners, as well as 10 patients with FTD and their study partners. And then the second phase, it was originally meant to target a smaller cohort, but because of the pandemic, we really ramped up quickly. And so with the support of the NIH, All FTD was able to reallocate funds to begin pilot testing of this app in the consortium. So the plan is to enroll 400 or 500 participants and their study partners. And the way we set this paradigm up is we're doing kind of a burst assessment in which they take the test 3 times over the course of about 2 weeks. They have 3 days to take each of the tests. There's a washout day. They have another 3 days, another washout day, and then they take the tests again. This triplicate of burst assessments will occur every 6 months for up to 5 years. All testing will be conducted remotely. So we're currently enrolling all participants who have mild dementia or are less severe. So far we've enrolled over 200 for the data I'll show you in a moment. We had 181 participants who enrolled from 18 sites starting in March of 2021. So we've been asking them a little bit about their experience to understand the feasibility of this type of paradigm. Participants have found that the task instructions overall, where most people say they were clear or between clear and neutral. There's some people don't find them clear. It's hard to tell. We have people with aphasia in this sample, so I don't know how much that's affecting this, but I'm not surprised that we see such, we see a bit of variance here. We asked them how difficult they were to complete. Again, we see a spectrum of how difficult people think the tasks are. Thankfully, not too many people find them very difficult. And then we asked them about their time to complete the tasks. They do about a 30 to 35 minute battery that they repeat those 3 times over the course of a couple weeks. And almost nobody said, no, this takes too much time. Some said yes, but less time is preferable. The majority said that the time is acceptable. And some people even said that they would do a little bit more if we asked them to. So I just want to show you one of the tests. This is the flanker test. This is a kind of standard paradigm of cognitive control or inhibition, as well as processing speed. This is in the kind of standard version of this paradigm. People are shown arrows, and they have to look at the arrow in the center and choose which direction it's pointing. And sometimes it's surrounded by, it's flanked or surrounded by other arrows in the same direction, sometimes in the opposite direction. What I'm showing here is performance at baseline and its association with their performance at their 2nd and 3rd visits. So you see really high test-retest reliability, split half reliability. This is with 100 iterations, was also very high. We're kind of seeing this across tests. I'm not going to show this right now, but just to say that our internal consistency estimates are between acceptable and excellent for all these tests, and as our test-retest reliability based on ICCs. And lastly, some brief, this is sort of really hot off the press construct validity work that we're doing in this sample by testing performance on these app tests with demographics, convergent cognitive outcomes, including a composite of UDS executive functioning scores that we've developed and the CVLT and the Benson figure recall. We look at some divergent measures. We have disease severity again with this FTLD CDR score and neural correlates as well. So when we look just into in the controls that are showing no symptoms, we see a strong positive association with age, as we might expect. So here you could see worse flanker performance with increasing age. This is our short-term memory tests, and they perform more poorly with increasing age. There's a small education effect for some of these tests, with higher education being associated with better performance, and small sex effects on a couple of tests as well. So all measures were strongly and positively correlated with the UDS executive composite that I mentioned. So here's an example where as people perform worse on the Stroop, they're performing worse on this executive composite. Our short-term memory test is strongly and positively correlated with the CVLT total learning. Tests were less associated with, excuse me, a measure of divergent outcome, so a visual spatial test. saw strong correlations with worse performance being associated with greater disease severity. Here, if you break it down into the global score on the CDR, so it's kind of like MCI, MBI, and dementia, we see this nice stepwise decline in performance that we might expect, and all these pairwise comparisons are all statistically significant. And lastly, we're showing in a small subset of people with imaging data that performance is associated with kind of related networks. This is a frontal parietal subcortical network volume and the flanker test, and medial temporal lobe volume and the short-term memory tests. So in there, we have future directions. We're doing a large normative study right now in conjunction with the Brain Health Registry, starting to collect data in a clinical trial, and we're working on Spanish and other language translations right now. So I want to end by thanking everyone involved. This app is a huge team effort. A lot of work from the beginning. I've been co-leading this with Adam Boxer. We have a work group of people that have been working on this as well. And then a thanks to the All FTD Consortium and all the patients and caregivers. And a special thanks to my mentors, including Joel Kramer, who provided some of the slides and videos that I showed here today. And if anybody's interested about training opportunities, we have a postdoctoral training program at the Memory and Aging Center. You can find more information here, and you can always shoot me an email if you have specific questions. So thanks. Sorry to run so late, but I'll take some questions if there's time.
Yeah, we do have a few questions, so we'll try to sneak a few of them in. So we do have a few questions about differential diagnosis. So I'll just kind of group those together. So what do you think is the best neuropsychological discriminator between frontal variant AD and behavioral variant FTD?
Ooh,
Started with a hard one, sorry.
I mean, molecular imaging or plasma blood biomarkers. I mean, I don't know. I mean, I don't know that I would ever put my money on a single test or even a subset of tests, really discriminating those two. I think looking at imaging, looking at atrophy patterns, and, looking at biomarkers as possible probably helps. I'm not going to go too far into that, but yeah, I think it's really tough. I think, one of the hard things about working with FTD is recognizing the limits of neuropsychological testing for differential diagnosis. I think there's a desire to be able to be really conclusive about these things based on our test results, and I think it's sort of humbling to realize that there certainly are limitations in this differential diagnosis.
You gave us a lot of example of some of the different speech behaviors. We had a question about the best way to tell the difference between NVF-PPA speech and PSP speech, variant speech.
Oh, and PSP, progressive supranuclear palsy?
Mm-hmm.
Yeah, so this is, I think, I didn't really get into this, but this is one of the challenges of studying this umbrella of disorders, is that these diagnostic criteria are highly overlapping. And so it is really common for a patient to come in with a behavioral variant FTD syndrome and for it to evolve into language deficits, or vice versa. And the same goes with PSP. PSP is usually caused by by FTLD tau pathology, which is also the most strongly associated pathological cause of the non-fluent variant of PPA. And so we often see, non-fluent syndromes as defined by the diagnostic criteria in patients with PSP. You might have an added layer of sort of Parkinsonian speech disorders there as well, but we will see sort of standard non-fluent patients there. There's been some work looking at this in path-confirmed cases. It's still pretty small. There's some suggestions that there's tends to be more dysarthria and non-fluent variants that are due to PSP pathology, but I think that's still being worked out. And I think what's sort of most important is the sort of larger clinical picture. What are the other motor features? What is the neurologic exam showing to help support, whether this is PSP or not?
So just like maybe having a little video of the two may look very similar. Having both those speech. Okay. Another question we had was just about your research as well. So I'll give you a chance to answer that one. So to what extent would you say your findings are generalizable to FTD in patients in other or developing countries, such as South Asia?
I think this is a really important question. I think there's a lot more work being done on trying to aggregate a global network to understand how these findings apply to different countries. I don't know if the question is specific to sort of some of the kind of technological work that we're doing, or if it's just kind of broadly about the research that I presented. I think there's a lot of work coming out now trying to understand how the language variants present differently in as a function of different languages, which have very different characteristics. And so I would kind of point you to the work of a lot of people working on this, but Marilu Guarnatampini and Boone Lead at our center are thinking a lot about this, and in the relationship and the interaction of language and PPA. I think, like I mentioned, we're trying to establish sort of a global network to really study this and understand how it differs. I think one of my hopes with technology as well is that it can possibly be scalable in a way that it can sort of reach a lot of groups, both within the United States and outside of the United States, that aren't often as represented in our research.
Yeah, most people have, access to something like this. It's a lot easier to transfer that than it is like actual stimulus materials and all that sort of thing.
Yeah.
So
And
that's
neuropsychologists, and yeah.
yeah. All right, well, thank you so much. We have next week's presentation is going to be at 4 p.m. Eastern, and we're going to be talking about ADHD across the lifespan. So I hope you can all join us for that. Thank you.
Great, thank you.
All right, thanks. Have a good rest of your day.
Thank you, too. Appreciate the invite again.